Good afternoon, everyone. We are Team Rosenthal, and today we are going to be talking to you about evaluating the effects of BFR training on static and dynamic balance in subjects with chronic ankle instability. So just to give you a brief overview of what our presentation is going to look like, we're going to start off with some background information, both about chronic ankle instability and blood flow restriction. Then we'll give you some insight as to how we conducted our research and our analysis of what we found. We'll discuss the gaps in the literature and the significance. And then we'll give you a brief intro as to what our study is going to entail, what our research question is, and our hypothesis.
As we previously heard from Dr. Bowija's group, blood flow restriction training shows great promise for populations who can't tolerate high load training. Our group is interested in chronic ankle instability and what effect BFR may have on this patient population. To date, there's very little research on BFR and the distal musculature of the leg. So let's take a few moments to understand a bit about each of these topics. Lateral ankle sprains affect more than 600,000 patients per year in the United States, with some estimates running as high as 1 million. Almost half of these occur during some type of athletic activity. Approximately 40% of lateral ankle sprains go on to become chronic ankle instability. Symptoms of CAI can include reduced range of motion in the ankle and foot, reduced static and dynamic stability, weak muscles of the lower extremity, especially the everters of the ankle, reduced postural control, and altered movement patterns during functional activities. CAI has also been linked to an increased risk of ankle osteoarthritis, reduced physical activity levels, and deficits in health-related quality of life measures. The most universal symptom that defines chronic ankle instability seems to be frequent episodes of giving way. This is defined as a temporary, uncontrollable sensation of instability or rolling over of one's ankle. Given the fact that some patients may have instability without structural impairments, it's hypothesized that CAI is a combination of both mechanical instability and functional instability. So, how do we determine which of our patient populations has chronic ankle instability? While there are a few studies looking at functional outcome measures as predictors of CAI, the accepted method to identify this patient population seems to be to use a self-reporting tool. 3 that are used frequently, probably due to their high reliability, are the Cumberland Ankle Instability Tool, the Foot and Ankle Ability Measure, and the identification of functional ankle instability. While the CAIT is used to determine severity, the FAAM is often used as an outcome measure, with its sports subset preventing a ceiling effect. The IDFAI is good at ruling out those who don't have chronic ankle instability. Taylor will later go over the functional outcome measures when she discusses current interventions for this population. Blood flow restriction training, as a review, let's look briefly at how it's done. A tourniquet is placed at the proximal end of the extremity. Here we see it's on the thigh, and in the lower extremity, the goal is to occlude blood flow in the artery between 60 and 80%, and this will completely block venous return. Typical BFR training protocol has a patient completing 1 set of 30 repetitions, followed by 3 sets of 15 reps each, using 20 to 30% of their 1 rep max. While BFR has been studied for use in both upper extremity and lower extremity, no adverse effects have been noted.
Okay, so now we're going to talk about the synthesis and analysis of our research. So when we first began this project, we split our research up into 3 groups. So we looked at BFR and general outcomes, current evidence for chronic ankle instability, and then articles that combined both BFR and chronic ankle instability. When we started BFR research, we found 2 main themes, and the first of that being studies that looked to compare BFR to low and high load training. There was a systematic review in 2017 by Hughes et al. That looked at the efficacy of BFR training in individuals that had musculoskeletal injuries. And what they found is that those who had BFR had an increase in protein synthesis and bone density. There was a reduction in muscle atrophy due to either immobilization or osteoarthritis. And they concluded that BFR strength gains were greater than those seen in those that had done low load strength training and the strength gains from BFR were equal to those who had done high load strength training. They concluded that BFR is a safe alternative for individuals that cannot undergo high load resistance training. And this is useful for populations such as post-op, people that have extreme amounts of pain that are unable to tolerate high load training, or osteoarthritis. The second main theme we found in blood flow restriction was studies that looked at muscle hypertrophy. So there was a literature review done in 2018, and they looked to review and summarize BFR benefits. They also concluded that it was an effective low load exercise program and that there were statistically significant strength gains in those that had undergone BFR training. And then we looked at articles that combined both BFR with exercise. So they combined BFR with aerobic exercise and also with resistance exercise. And they found that in both groups, there was an improvement in muscle hypertrophy and in strength. But they concluded that that BFR should not be used as an isolated treatment. It should be in combination with other types of interventions. So now Taylor is going to give us more information about chronic ankle instability and current interventions in research.
These 4 literature points are what stood out to us the most when conducting our literature review of chronic ankle instability rehabilitation. I will discuss each point at greater length in the coming slides. 1, there are different selection criteria for different studies. 2, the development of CAI is concerning. 3, there is no difference between some forms of rehab for CAI. They all get better. 4, balance and proprioception training is key. Again, there is different selection criteria for different studies. For example, a study by Wright et al. In 2017 used the following inclusion criteria. Subjects needed to have 1 or more inversion ankle sprains and scored no more than 25 on the Cumberland Ankle Instability Tool. This is just one broad perspective on how to classify CAI. Other studies also use the CATE and other questionnaires like the Foot and Ankle Ability Measure and the identification of functional ankle instability, like Susan mentioned earlier. In 2014, the International Ankle Consortium published a position statement to address these inconsistencies. They proposed these threshold scores for the questionnaires. The Cumberland Ankle Instability Tool cutoff was 24. For the Foot and Ankle Ability Measure, the cutoff was 90% on the Activities of Daily Living scale and 80% on the Sports scale. Lastly, the identification of functional ankle instability minimum score was 11. In that same position statement, the IAC also addressed potential confounding factors that should be considered when designing a study, such as the timing of the injury, the quality, and the current activity level of the participant. One way to measure current activity level is through the Tegner scale, which considers the person's occupation and type of physical activity. Another is the Godin Leisure Time Physical Activity Questionnaire, which considers the type and quantity of physical activity. Between these proposed cutoff scores and potential confounding factors, using this information to design future studies will enhance both their internal and external validity. A second point is that the development of CAI is concerning. One prospective cohort study looked at how motor control deficits can be used as a predictor for first-time lateral ankle sprains developing into CAI. 82 participants who sustained a lateral ankle sprain were asked to complete 5 motor tasks at 2 weeks, 6 months, and 1 year after initial injury. The results demonstrated that an inability to complete a single leg drop landing and drop vertical jump at 2 weeks were predictive of a CAI outcome. Out of the total participants, 40% developed CAI. This study helps conclude that acute motor control deficits may lead to chronic instability. Interestingly, this study also found there was no statistically significant difference between those who sought rehabilitation for their acute lateral ankle sprain and those who did not. This data was included as a subjective yes-no answer to whether the participant had received additional rehab beyond standardized emergency room recommendations of rest and compression. The purpose was to establish no difference between participants because the primary objective of the study was to determine tools for early identification of those with a high risk of progressing to CAI. Unfortunately, it is unclear exactly what kind of rehab the participants received and from what type of practitioner, as this information was not collected. Nevertheless, this study looked at those who became chronically unstable and those who did not, so it is concerning that acute rehabilitation did not produce a significant difference. In summary, the purpose of sharing this study with you was to tell you about the people who developed CAI and that acute rehab may not make a difference. A third point in the literature is that there is no difference between some forms of rehab for CAI. The bottom line is all interventions work, but one is not necessarily better than another. We don't know which type of rehab is the best. For example, this study looked at resistance band training and PNF resisted D1 and D2. They found both groups had the same results. They improved in their inversion-eversion strength and some aspects of dynamic balance. However, they did not get better in other forms of dynamic balance. Again, there was no significant difference between groups. Here is another example. This study looked at wobble board balance and resistance tubing. They also found that both groups had the same results. Both groups improved in measures of static and dynamic balance. Again, there were no significant differences between groups. This is a table of the dynamic balance outcome measures that were used in some of the studies for your reference. For example, the Y balance test is one we did in class. This is another table describing static balance outcome measures that were used in the previous studies, which I also provided for your reference. If you have any questions, we can talk more about them during Q&A. Based on what I showed you earlier, different forms of rehab can produce similar outcomes. However, some studies have determined that balance and proprioceptive training alone produces improvements in static and dynamic balance as well as proprioception, which may be some of the most critical components to rehabbing CAI. This might seem like a no-brainer, but some of the studies we read did not include balance and proprioception in their rehab. The bottom line is if you want to see improvements in balance and proprioception, it needs to be included in the training. Additionally, 2 other studies compared the effect of adding balance to strength training protocols. Significant improvements were made in groups who included balance in the strength regimen, as evidenced by improvements in both static and dynamic balance. This brings us to our method of strength training, BFR.
Okay, now we're going to talk about BFR and chronic ankle instability. So currently, a study done in 2019 by Killinger et al. Is the first and only study to examine the effects of BFR in participants with chronic ankle instability. The study had 2 groups. One used BFR with 80% limb occlusion pressure, or LOP, and the control group wore the cuff during the exercises, but it wasn't inflated. They measured EMG muscle activation and hypoxia of the tibialis anterior and fibularis longus. This was done during dorsiflexion and eversion isometric exercises at 30% MVIC, or maximum voluntary isometric contraction. What they found was that the BFR group had greater muscle activation and oxygen saturation during the exercises, with dorsiflexion being the only clinically significant outcome with moderate to large effects. Eversion exercises showed a small to moderate change, and they did not consider them clinically significant. In conclusion, the increase in muscle activation and oxygen saturation can lead us to theorize that higher threshold motor units and muscle fibers are being recruited in order to complete exercises with BFR. So this research study can be used to back up future studies like ours with BFR and looking at the distal lower extremities, but using more functionally based outcomes, such as the Y balance test. Now Natalie's going to talk to you about gaps in the literature.
All right, so we wanted to talk now about some of the gaps in the literature that we found, and the first gap being a population gap. So we found that there was little information looking at chronic ankle instability and BFR together. As mentioned by Alex in the last few slides, Killinger in 2019 was the first study that looked at CAI and BFR, and we believe that it's still the only study to do so. We found this to also be just a general theme throughout our research, that there were really few studies that looked at the distal ankle musculature in general. Bowman in 2019 studied the lower extremity, and they looked at the effects proximal, distal, and contralateral to the cuff placement for BFR. And they found that there were positive effects in ankle plantar flexion and in heel raises, suggesting that BFR effects can be seen down in the distal ankle musculature, but that there really hasn't been many studies that have looked at this yet. And the second gap that we wanted to mention was some outcome measures. So we found in general that there's really not many studies that look at outcome measures such as balance, proprioception, or any of those ankle outcome measures that we mentioned earlier. Most of the studies, as we've mentioned, have looked at large global muscles, muscle hypertrophy, oxygen saturation, and strength with high load and low load training. And in the Killinger article, they looked at EMG activity, but they mentioned that it would be really important for another study to look at some of these outcome measures and some balance and proprioception for the CAI population, because this could really give us a good idea of how BFR can be used clinically for this population. So the two main gaps that we looked at were that population gap with CAI, and then some outcome measures that we feel have been missing from a lot of the BFR articles. And now that we've talked about these, Megan is going to give us a little more insight into some of the significance of our research.
Now we will address the why of the research. Why is the study significant to us and to the practice of physical therapy? Despite there being a rapid increase in interest in research related to BFR in recent years, there is little research on the effects of BFR on chronic ankle instability. Current rehabilitation for CAI involves a combination of strength, balance, proprioceptive, and flexibility training. Currently, there is research and evidence which supports the use of BFR in low limb strength training. Therefore, there is reason to believe that BFR may be beneficial in the rehabilitation of CAI patients in order to increase strength of muscles that stabilize the ankle and foot, preventing future injuries related to ankle instability. What remains unknown is the effect BFR training has on static and dynamic stabilization, both within the training session as well as long-term outcomes. Implementing the most effective treatment to optimize patient outcomes is critical to the practice of physical therapy. Lateral ankle sprains are the most prevalent musculoskeletal injury within the athletic and physically active population. Without proper treatment, these sprains can lead to a variety of other health-related problems, including ankle osteoarthritis, sensory motor deficits, and chronic ankle instability. As technology and resources available to physical therapists are constantly evolving, it is essential to ensure that patients are receiving treatments proven to be effective. Due to little research having been done on the efficacy of BFR training on CAI, this research will assist physical therapists in determining effective interventions for treating CAI patients. And this leads us to a research question. For our research, we will be examining what is the effect of BFR training in young adults with CAI and how does it impact static and dynamic balance within this population. And now Alex will discuss how we will conduct our study.
Okay, I'm going to talk to you a little bit about our study. So to start out, we will have a familiarization session with the participant. They will need to pass our screening form and have a greater score than 11 on the IDFAI. We will gather more information about them using the FAM, as well as the Tegner and the Godin Leisure Activity Scales. These documents will be answered prior to the study and after the study is completed, and we will compare the results. These surveys will provide us more information on the individual's current activity level and the perception of their functional limitation. So to answer our research question, we will use a force plate to measure static balance and then ask the subjects to complete a lower extremity Y balance test while standing on the force plate. Testing will be completed prior to BFR application, immediately after BFR training, and then after a 10-minute rest period. BFR training will consist of standardized test sets and reps of single heel raises and split squats. Participants will come in for a total of 5 sessions, which includes the familiarization session. So we will need 27 participants to account for dropout. Is anyone interested? For our hypothesis, we think that immediately following BFR training, we will see a decrease in postural stability, mostly due to fatigue. 10 minutes following BFR training, we will see a postural stability return to baseline or equalize to baseline. At 2 weeks following 4 BFR training sessions, we will see an increase in postural stability. And then lastly, we think that individuals with lower activity levels will experience greater deficits in postural stability measures prior to and following BFR. And these are our references. Thank you guys for listening. Do you have any questions?